Everyone for joining us. This is our third session of the day, and we have one more after this, so just a continuation of day 3. I'm going to allow Emily Brighton. She's the Vice President of Professional Services at MedStar Washington Hospital Center, and she will be introducing our speakers for this next session.
Great, thank you, Elizabeth. Good afternoon, everyone. As Elizabeth mentioned, my name is Emily Brighton. I'm the Vice President of Professional Services here at MedStar Washington Hospital Center. This session is focused on the impact of the pandemic on opioid use patients. Presenters from MedStar Washington Hospital Center will discuss how the ED-based opioid response grants, data review, and frontline patient experience have been used to meet the needs of OUD and SUD patients during the COVID-19 response. Our speakers for this session are Dr. Lourdes Griffin, Samantha Brannigan, and Keith Martin. Dr. Griffin studied at the University of South Florida in Tampa, Florida, and earned both a master's and doctorate in clinical psychology. Dr. Griffin is a clinical psychologist licensed in Maryland and the District of Columbia. She has over 25 years of clinical experience working with patients spanning the age continuum and has provided services in both hospital and private practice settings. Dr. Griffin is currently the Assistant Vice President of the Behavioral Health Service Line at MedStar Washington Hospital Center. Samantha Brannigan is our Patient Care Manager in the Emergency Department at MedStar Washington Hospital Center. Sam graduated with a master's degree in nursing from University of Maryland School of Nursing. She has been a nurse at Washington Hospital Center for over 6 years, with 2 years being in her current leadership role. Samantha has worked with the ED MAT program since it was established at Washington Hospital Center in 2018. Keith Martin is an Overdose Survivors Outreach Program, or OSOP, coach at MedStar Washington Hospital Center. Keith has been working at MWHC since September of 2019. In this role, he cultivates relationships with community treatment providers and recovery support services to evaluate appropriate resources for patients. He follows up with patients at treatment facilities, assists with securing supports related to medical needs, and connects individuals to various recovery supports, including workforce development. Thank you so much for attending today's session, and I will now pass it over to you, Dr. Griffin.
Thank you, Emily. It's my pleasure to be here with you today. I'm wondering, Elizabeth, if the slide presentation is being shown. Thank you. Thank you. I was going to search for my own. That's great. So here at MedStar Washington Hospital Center, we're participating in the opioid response for the district. And we started our program in April. It's been over a year now that we have been working with the emergency department. This program is under the emergency department. We've been fortunate to be able to provide services to patients in need of recovery. So I'll talk to you a little bit about the overview of what the screening, brief intervention, and referral to treatment program does. But the bulk of the work will be presented to you by Sam and also by Keith, our peer recovery coach, who will let you know what it's like to be working one-on-one with these patients. Most of you probably do know, but SBIRT, or the Screening, Brief Intervention, and Referral to Treatment Program, is a program that allows us to quickly screen patients and assess the severity of their substance use, evaluate what is the appropriate level of care for them, and then refer them for brief intervention. There's counseling that goes on in the emergency room, seeing their level of motivation through motivational interviewing and identifying what type of treatment they may be ready for or willing to accept, and then making a referral to those treatment. Referrals are made, and in most instances we would like to have a warm handoff referral, which is one where the patient is connected directly with the treatment facility and sent from the emergency department. You will hear from Keith how there is follow-up that occurs for patients that need to be medically admitted first, someone who has had an overdose or needs medical stabilization of some kind before they can go to a treatment program, may be admitted to a medical or psychiatric unit and followed by the peer recovery coach while they are in the hospital. This also facilitates their access to care and make sure that they don't fall out of the sort of continuum that we're setting up for appropriate treatment for them. Okay, next slide. Medication-assisted treatment is happening in our emergency room now. It is a method of using medication in combination with behavioral therapy to treat opioid disorders and reduce opioid-related deaths. There are 3 FDA-approved medications for use with medication-assisted treatment. They are methadone, buprenorphine, and Vivitrol. The research from the Yale School of Medicine studied the use of buprenorphine in the emergency departments and concluded that when buprenorphine is given in the ED as a form of medication-assisted treatment, patients are more likely to engage in substance use disorder treatment and reduce their opiate use. It's very difficult when a patient is beginning to withdraw from substances to guarantee that they're going to make it to the treatment facility. They oftentimes have significant cravings and a need physiologically and psychiatrically for that substance. So this medication-assisted treatment format allows greater success in linkages. Okay, next slide. We have an overdose survivors outreach program, and Keith works in that program most of the time, although he's currently covering our emergency department as the peer recovery coach there. But this is a specific program that came about as a little bit later, a little bit after our original ED medication-assisted program. And it is for individuals that come to the hospital who have overdosed. They're in our emergency department and they are not willing to go to treatment. They do not want to be linked to treatment. They do not want medication assistance to get linked to treatment. So the Overdose Survivors Outreach Program or coach will focus on those patients who have experienced an overdose. As you can imagine, they're very high risk and would pose a danger to themselves. So these patients, they're referred to the Overdose Survivor Outreach Coach, who will engage with them in the community wherever they may be. So Keith works with them now in the time of COVID, which is what you're going to be hearing a lot about in this presentation, and how COVID has affected and how this program and how we have modified our interventions to continue to provide care in a different way. Keith will follow these patients telephonically for now, or before it was in person, and connects with them for 90 days, hoping to link them to recovery support services and hoping to conduct interviews and counseling with them. He also assesses their willingness to change for when they are actually ready to seek help. When the individual is ready, the OSOP coach connects them with one of the treatment providers that we work with. Next slide. So we're wondering, I keep talking about Keith and that he is our peer recovery coach. Well, what is a peer recovery coach? Keith is employed by the hospital, as are several others. He is an employee with experience in coping with substance dependence and is in recovery. This person uses their life experiences to help patients with substance dependence. A peer recovery coach supports patients in screening, brief intervention, and referrals to treatment. Next slide. Now you're going to hear about the emergency room from Sam Baldock, who is our nurse manager in the emergency room that works with this program. I think this is your slide, Sam.
Thank you, Desi, and thank you all for having me. So the ED perspective on SBIRT. So it is a team-based approach, and it provides an easy connection for the patient for treatment, and then therefore results in just overall better outcomes for our patients. It also starts a very positive patient relationship with the peer recovery coaches and with the nurses in the ED. It's easier for the patient to relate to the peer recovery coaches rather than a healthcare worker. I'm especially hearing that from nurses because those peer recovery coaches have had experiences that some of these nurses can't necessarily relate to and can help them go see things in a different way. They're also help with accessibility to resources. A lot of times nurses are very busy in the emergency department, and although that we do have the accessibility and knowledge of the resources, we don't have that time to really sit and talk with the patients about the resources. The peer recovery coach's role within our ED is so incredibly important because they can really sit there and have intimate conversations about, one, like I said earlier, their experiences, but two, talk a little bit about the resources and options that these patients have. Additionally, they can help facilitate the transition of care for these patients as well. We've talked about Keith a lot in this, and I know Keith has had a very large role in helping facilitate this transition of care for our patients. It helps alleviate the issue, the time spent for nurses so they can be doing more medical needs and knowing that these patients can still get the help that they need. The process helps identify vulnerable populations that may have previously been overlooked as well. A lot of times we have seen that patients will come into the emergency department with something completely unrelated to anything substance abuse. Upon speaking to these patients and completing the SBIRT with the patient, we will find that, perhaps this patient did have a substance abuse issue that will trigger for the peer recovery coach to have a brief intervention with that patient and talk more and start the process with them. A lot of the nurses have really loved this opportunity because this is a patient that may have been overlooked and now is getting that in-depth extra care that they need. Next slide. Here's just some statistics from our ER right now. And I specifically wanted to put this because I do want to talk a little bit about how COVID has hit us a little bit. As you can see, our numbers did lower. January was about our normal numbers. And towards about, let's see, March, April, May, you can see that our overall, the blue bar shows that our number of ED encounters has dropped. But you can see that our number of SBIRT completions still pretty much stayed the same. A lot of it some are not completed because just severity of patient, maybe CPR in progress, things like that. But we still are completing those SBIRT forms. Additionally, our positive SBIRT rates have pretty much stayed the same, even with our numbers going down. But we have seen a lot of issues with COVID, and we have tried working with them. Elizabeth, could you do the next slide for me, please? Thank you. So the COVID-19 impact in the ED with MAT program and the OSOP treatment models. Like I said, we have ran into some issues with having COVID in the ER and had to change our model in some ways. For example, the peer recovery coaches are unable to complete any brief interventions with patients that are COVID positive patients or PUIs, patients under investigation. Now, remember, a PUI can be really many, many things. Someone with a runny nose, someone with a cough, someone with nausea. So a lot of our patients, as you can imagine, are PUIs here in the emergency department. And therefore, those patients who could be benefiting from that brief intervention with the peer recovery coach are not then able to get that brief intervention. We have found, though, with some trial and error, that we are able to find some alternatives that help us still have that communication aspect with the patients and helps that peer recovery coach be able to have their brief intervention. For example, we have installed phones. Previously, we didn't have phones in every room. Now we have phones in every room, especially rooms that are a negative pressure room or a room with a positive, that would hold a positive COVID patient. We've been able to have the peer recovery coaches then speak to the patient using these phones. I've gotten a lot of feedback that's been really great for the patient and from the peer recovery coaches. I know Keith and Christina have both said, and some other peer recovery coaches have both said that has been a really nice way of still being able to have that communication with the patients. Additionally, they've had to just wait in general for clearance. A lot of times we can clear some of these PUI patients of their status, and they can be someone that eventually the patient or the peer recovery coach can see. So that's sometimes a waiting game there, which is why if we feel like they really do need that brief intervention early and quickly, we can utilize the phones. Additionally, the OSOP role has been affected as well. Community outreach aspect has been halted for right now due to the COVID concerns. But speaking with Keith, who is our OSOP, he's still able to connect with these patients virtually. So despite the issue or the problems that we have seen with COVID, we really have tried to be innovative with still keeping the brief interventions available and keeping that communication, which I think is so important for these patients. Next slide. I think this is more for the peer recovery coaches. So, yeah.
All right. My name is Keith Martin, peer recovery OSOP coach role. Recovery guidance, peer model based on lived experience and mutual support. The peer recovery coach and the OSOP coach, they use his or her own story as a means of offering testimony to the reality and power of recovery. This uses his or her own story as guidance on how to live in recovery. Peer recovery coaches and the OSOP coaches are non-clinical. The recovery model that is integrated into behavioral health. Referrals are made linking people to treatment in the community. I wanted to start off by explaining what I do in the ED and what I would do as an OSOP coach. From March 12th, I have been in dual roles. I'm doing both. So I'm going to give you a step-by-step view of, I'm just going to use one patient. We're going to call her AG. Last week, AG came into the ED at 2:30 p.m. Heroin usage. So even before she got in the back and the SBIRT was done, the nurse notified me, and I went and talked to her in the waiting room. She immediately wanted help. So the first thing I do when it comes to opiates is I utilize our MAT program. So I asked when was the last time she used. She told me this morning. So between 12 and 24 hours after a patient has used, that is the time where you would administer your buprenorphine. At our hospital, I have noticed that Suboxone, which is the street name, has now a second medication has been added to that. So we are giving patients 8 milligrams of Suboxone and then combined with 2 milligrams of naloxone. So the patient comes in the back. So the first thing I want to do is I want to ask the patient, are you in withdrawals? And she said yes. So my next step is to go to the doctor and let him know that I have a patient. And the nurse is going to do the opioid scale, which we call COWS, to determine where this patient is in their withdrawal. If she scores over an 8, we know that she is in withdrawals. If she scores anything under an 8, we'll redo that test in about a half an hour. So while the doctor was talking to this patient, we found out that she actually had used an hour ago. So that would have posed a problem to the patient because you use that soon and then you get some Suboxone, she would have gotten deadly sick. So the patient wanted to get into a withdrawal program. So here in DC, we only have 2 detox centers. That's PIW, that's in the 4200 block of Wisconsin Avenue Northwest. And then we have RAP, okay? Regional Addiction Prevention Program. That's on 4th Street Northeast. So I knew I had to get her to one of those. So the first thing I would do, I did the brief intervention. I found out her history and what she wanted to do. I let her decide. I just gave her the options. You can do treatment, you can do detox, you can do outpatient, you could do an MAT program. She chose to do detox, and then once she detoxed, she would go into a program. So the doctor had already ordered the buprenorphine and the naloxone mix, but fortunately we found out that she had just used. I called a doctor just to confirm once a patient uses, how long you would have to wait before you could administer. He gave me a time frame of between 12 and 24 hours. So I'm worried because it's already 2 o'clock, 2:30, almost 3 o'clock now, and this patient has Medicaid insurance. So any person who has Medicaid insurance in DC and they want to get into treatment, they have to go to one of our APRA locations. There are several throughout the city. There are 2 in Anacostia. You have MBI and Family Medical. You have ARC. They have 2 locations, 35K Northeast and then 75 P Street Northeast. Then you have Andromeda, which is a virtual assessment program. So once the peer recovery coach does the BI, the brief intervention, the patient decides they want treatment. The first step, particularly with PIW and RAP, you must send over the patient's clinicals and consent forms. The clinicals pretty much are the patient's history as long as they had been in the hospital. So I did that. Now it's 3:30. I'm worried because, well, fortunately, PIW and RAP's withdrawal programs are 24 hours. That was not the case a while ago. So I got a call from RAP. They accepted the patient. So she is now at RAP in their withdrawal program. A patient withdrawing normally is between 3 and 7 days, depending on how the doctor feels about it. So I have talked with the patient. That is one thing that I do. So that is the peer recovery role. The nurses do the screening. We see it. We do the brief intervention. We find out what the patient wants. If the patient wants treatment, we use our resources and experience, and we get that patient a warm handoff. One of the best components of our ED department is that if a patient wants treatment, the best way to go is bed to bed, because we do all the paperwork. The only thing they have to do is be willing to go. And we put them in a cab, thanks to MedStar Washington Hospital, which makes everything very simple. We get them straight to the door. No, you cannot go home. No, you cannot pick up no clothes. Have your mom bring them. Get them straight to the program. So in my OSOP role with this patient, because she was using opioids, that would be a referral to me. So I would, most of the time they do go to treatment. So what I have learned to do is I give the patient my card. Sometimes they forget this second step, but I remind them, I say, when you get to treatment, you are going to do an intake. You're going to have to sign a consent form for people to be able to call you. Please put my name on there. So I've been able to contact patients while they're in the treatment center. How has COVID affected my work? When I heard about COVID back in February and March, I knew it was serious. I wasn't playing. I took it seriously. And when they said you can't go out, I understood why. I didn't get mad. I understood. And so did the patients that I worked with. They took it serious. The bad part about the beginning stages of COVID was that trying to navigate and help a patient over the phone. It's much more difficult over the phone than going to that patient. I never met a patient at their house. I would meet them at a McDonald's, library, at a park. Then we would go or buy a resource center that they wanted to get something from. Let's see. So the bad part about COVID was that piece. But over time, it got easier. Now, the good thing about COVID as it relates to my job is that society has assimilated and they've adjusted. For example, AA meetings and NA meetings are over the phone now. You only have to leave your house. Outpatient services for patients who want treatment over the phone and Zoom. You don't have to leave your house. So it makes things easier. Doctor's appointments. Andromeda is a assessment and referral center here in DC. And Family Medical over in Anacostia. These two places I like the most because while a patient is here in the hospital, we can call them up and do the assessment and referral and get them to treatment. Two of my success stories, I wanted to tell you one of my success stories. I have a patient, we're gonna call him VA. He came in intoxicated. He said one of the questions we ask a patient is, have you ever had any sobriety? How long have you stayed clean the longest? He couldn't answer that question because he never was clean. He had a barrier. His wife has stage 4 cancer. So he couldn't do inpatient. So the good thing about outpatient is that some patients have a job. Some patients are the breadwinners of the family. Some patients have an apartment. So they can't go into inpatient treatment. So the other alternative is either an MAT program or outpatient. So this patient, we used alcohol. So what I did is I got him to PIW and I introduced him to Vivitrol. Now, I thought that when I first started this job, it was only for opioids, but it is actually used for alcohol. So PIW kept him for 10 days. I got him also connected with an outpatient program. He was a Maryland resident and they took him quickly. So he got his detox. We actually call it withdrawal management. I got to start using that word. He got withdrawal management and the doctor said you need to be clean 7 days minimum for the Vivitrol to work effectively. Now with opioids, a Vivitrol shot is given to a patient once every 30 days. So buprenorphine and methadone, you take that daily. But Vivitrol, it's one shot every 30 days. So the patient got the shot. With opioids, this shot will help curb cravings. And in the beginning stages, it will curtail the withdrawals, the pains and the problems that this patient goes through. But with the alcoholic, the Vivitrol shot is a deterrent. It kind of helps with the withdrawals, but by that time you take the shot, you've been clean 10 days, so your withdrawals are over. The cravings it helps with. But the biggest deterrent is that if you take one drink, you will get deadly sick. Now, I've told several people this. Nobody wants to do it. He is the only person that did it because he said, that is the only way that I won't drink. And as of today, he's just celebrated 132 days. My second person I wanted to talk about, we can call him KB. KB, alcoholic, opiates, came into the hospital, homeless though. I have helped this patient. I think I met him back in January. I've helped this patient get his driver's license. He needed a bank, but he didn't have ID, so we got him a NetSpend card. During COVID, I got him his birth certificate and social security card. When he finally got his ID, his driver's license, I helped him go online and open up a bank account. We got him a cell phone. I tell patients, and a lot of patients don't know, but if you have Medicaid, you can get a free phone. You use, the carrier is SafeLink. You go on SafeLink, you fill it out. There's a space to put in your Medicaid number or your food stamp or SNAP number. And then finally, So he's doing well, but he is still homeless. Housing, some people, that's how he wants to live. So when I was out in the community, Kevin didn't have a phone at first. So I knew he would always be on New York Avenue, where New York Avenue and North Capitol intersect. And every time I went by there, I'd see Kevin on the street. Pre-COVID, I'd get out the car, I'd talk to Kevin. So that was how I interacted with him. The last piece I want to talk about, I really want to give some props to Unity Healthcare, Dr. Roby. Unity, if a patient comes in on opioids or heroin, literally within 1 hour, well, let me tell you what I do. The patient wants outpatient services and he wants Suboxone. So the first thing I do is I email my contact, Mr. J. Please give me a call. I then go and fill out the 10-page questionnaire and I fax over the patient's clinicals. When Jay calls me up, I go to the patient, we do an intake, get all of his information. And then Jay sets up a doctor's appointment that same day. So if a patient comes in at 9 a.m., by 10 o'clock, we would have done the intake. By 1 o'clock, the doctor calls him up, asks him the necessary questions to see what level or dosage of Suboxone he needs to be on. And then that doctor sends a prescription to the patient's nearest pharmacy. So the connection is right there. So pretty much this has been it's been a great experience. It's worthwhile. I was a former accountant, HR and payroll manager. I decided to do something different, and it has been very rewarding.
Awesome. Thank you so much, Keith and Dr. Griffin and Sam. I think your varied perspectives together are really important. And Keith, especially the work that you shared at the end is awesome. I want to encourage anyone who has questions. We do have some time, so you can use the Q&A feature at the bottom of your screen to submit questions for any of the presenters. And we do have a few. I want to talk a little bit more about telehealth, and I think, again, you all might have different perspectives on that. What has it been like, both in the ED setting, technically, if it's like when you're using phones to talk to patients' rooms for a brief intervention or something like that, as well as, of course, outside and referrals to providers and things like that. What has been your experience with that, pros and cons? What you think
about a little bit about the outpatient behavioral health side. We began doing telehealth for therapy. We actually did telehealth for groups as well, because we have intensive outpatient groups and a variety of different groups for our patients here at the hospital, and it's actually worked very well. It was a little bit rough in the beginning because there's some older patients, of course, that may not have smartphones or may have trouble figuring out how to do it. So for those patients, we would have the medical assistant call them first and try to link them up before they came onto their appointment with the physician or the therapist. But as time went on, people got better and better. And at our patient behavioral health service, we have a lot of space, and there were some patients that really needed to come in person, patients who needed injections, patients who needed, they were more fragile and needed groups, or they were elderly and just were not as comfortable talking to their doctor over a Zoom call, although phone calls did work as well. So we've done a large amount of our therapy visits as well as our groups via Zoom, and we continue to do so. We've opened up somewhat, and some of our programs, like our partial hospitalization program for the patients that are very more acutely ill, those are in person. They are in-person programs in a socially distanced atmosphere. But it's been very, very helpful. We do a lot of the evaluations for the medical patients via Zoom, via iPads. On our inpatient service, because we don't have visitors readily, we've had to work with case managers and people in the community and family members for family meetings, all using sort of tablets or devices. So it's a different way of working, but one thing that it has helped is our no-show rate is significantly better when we're doing Zoom, because there's no transportation issues, there's no granddaughter who was bringing them who couldn't bring them, or the taxi that didn't come. So that's been an interesting side effect of that. But that's how it's being used in the behavioral health service, as well as for COVID patients when we need to do behavioral health interventions and they're on a medical unit or they're at home quarantining, you can still continue to provide their care. Sam, I don't know if you wanted to say something about the ED use.
Well, for telehealth, I guess for just in general with nursing, we're still using it a lot for patients that come in to see us, just kind of starting their workups in the front. But more with relating to SBIRT and the peer recovery coaches, I think Keith might be able to give a little bit more aspect on that, like with using the phones, because we haven't used telehealth for this particular program in our ED in relation to the
Yeah, while I was explaining what I did, I gave some good examples. I guess the most beneficial telehealth is the assessment and referral centers, or the treatment centers, where you can do the admission and everything over the phone. It really helps. In addition, with telehealth, the AA meetings now, AA meetings, you got 100 people packed in a room. We can't do that no more. So I give patients a list of phone numbers, Zoom websites to go to, and then the outpatient services. And then with Unity Health, I explained the process of how I get a patient who comes into the ED, and we get them connected by the end of the day to his Suboxone prescription. Because of COVID, most of the outpatient places, they're giving patients 7 days, 14 days, or month supplies, so they don't have to keep coming back. So that telehealth, and I really think that they're going to keep, even once we get a hold on this COVID, I really think they're going to keep a lot of this, because it helps. It's much easier.
What about the providers, the kinds of resources, Keith, you were talking about, like Social Security card, driver's license, places like that? How has your connection or your work with them shifted during COVID?
Yeah, I just celebrated my 1-year anniversary here, and the whole time I've been keeping this spreadsheet, every resource I've got, and it has blossomed. And at the bottom, I keep it alphabetized because I'm a neat freak, but I have maybe 20 to 30 resources. So one of my gentlemen, he needed a Social Security card and he needed his birth certificate. So of course that's vital statistics and then the Social Security Administration. It took hours to find the exact number and website and the forms, but once I found it, it's there for life. So I put that on my spreadsheet. DMV, setting up an appointment. Oh my, DC is crazy. Last month I had to set up an appointment. They talking about February.
Oh my gosh.
I'm in Maryland. It's like a week or two, at the most a month away. But he was like, February. I was like, hey, it's nothing you can do. So, the telehealth is a very positive aspect. And I mean, my job is connecting with people in the community, and I can't get to them. So what do I do? Last month, I had 186 contacts. And that consists of actually connecting with the patient over the phone. They've also asked me to keep track of when I called and they didn't pick up. And then there's the family members I talk to. Sometimes I talk to the family members more than the patient. The one thing I did not talk about is in this job, there was a young lady, she got discharged on Friday to MBI. 6:30 Saturday, she calls me. I used. One of my guys, Tuesday, 9:30 p.m. Hey man, I feel like using right now. So, the one thing they told me is don't get overwhelmed, keep your life balanced. But if somebody calls you at 11 o'clock at night, I'm thinking about using, if you have the empathy, if you have the care, you're going to help them. So I always answer the phone because it hasn't got overwhelming yet.
Well, I hope that we can get you some help so that you're not the only one answering the phone, but you're doing a great job.
Yesterday was one of the first times I got overwhelmed because at the end of the month, I do some reports to help, to help us out. And I got to call my OSOP people, and I got to do the peer recovery, and my colleague got sick. So I'm by myself, and for the first time, 12 referrals from patients upstairs. When I first got here, after about 2 months, I noticed that the case managers and the case workers and the social workers and myself, we were kind of clashing. We were doing the same things for the patient. So I asked Aisha, she is with Mosaic, if she would help me put on a presentation. So we had about 100 social workers in the room, and we just did a presentation on what we did. But the one thing we told them, we are exclusively for the ED. If you call us and we have the time, we'll help you. I did get 5 referrals from behavioral health, and these patients were being discharged. So I had to get to them immediately. So it was kind of a hectic day.
So I think the whole team is really grateful, especially right now, holding down the fort. So thanks for that.
Thank you, Keith.
I think we do have a couple audience or attendee questions, and you touched on a point there, Keith, I want to come back to in a minute about wellness during COVID. But one of the questions that the attendees have asked, using the SBIRT, at what point do you make the patient aware of the risk with whatever the individual is using? So where in the process do you have that conversation?
I can start with that, since I think it kind of starts technically with the nurse first, since the nurse is the one who completes the SBIRT form. A lot of times, like I said earlier, they may be in for something else, and every nurse or nurses have to complete an SBIRT form on every single patient. So that can kind of trigger for someone who may be here for some unrelated issue. Upon that time, if they are finding that the patient does say yes to any of the substances, whether it's alcohol, even marijuana, opiates, any of those on there, they usually have a discussion, obviously with educating the patient on why they shouldn't be doing those things, issues behind them, etc., and give them a little bit more education on that. I know that, so that kind of starts out the process there, but then that patient will then trigger to the peer recovery coach, that they are someone that would need a brief intervention. And I'm sure from there, Keith or one of the peer recovery coaches go further into that, and I'll let Keith kind of go into that portion then as well.
Yeah, from the lowest scale to the highest, of course you have marijuana. Literally 95%, they say I'm good. I don't have no problem. I don't need treatment. I just do it a little bit. So what we do is called harm reduction. So the first thing I explain to them is, where do you get it from? Do you have a card? Because the dangers of marijuana now is that the chemical sprays and the other additives that they are putting and mixing with it, and once they spray it on and it dries, you can't tell. So it's just harm reduction. With alcohol and other substances, some patients don't want treatment. They're not ready yet. They haven't had enough pain. They haven't hit their bottom. So you try to introduce, can you drink less? Can you smoke less? So harm reduction, of course we want abstinence, but that's about it.
And then, of course, upon discharge as well, whether the patient does go for treatment or they decide to not go forward with treatment, that is part of the discharge instructions as well. Just going through exactly what Keith said, and then just kind of educating them a little bit more on substance abuse and their options if need be.
multiple times, it sounds like, throughout the care continuum there at the hospital. So thank you. Another question we have is kind of a two-parter. What kind of resources or training do ER departments need to successfully link patients to appropriate treatment resources like community providers? And then on the other side, what would you say are the resources or qualities community providers need to work effectively with the ED on these issues? So just highlighting some things that you think are strong about that make your program work from both the ED perspective and the provider perspective.
Well, I could say from like ED nursing perspective, whenever this program started, we did a lot of training with our nurses, educating them on what it is, a lot of in-services, and saying exactly what the program is going to do, what it allows us to give to these patients. So giving them an overview during that time whenever we first started this. Additionally, we have training throughout pretty much the year. Every month we have huddles and we talk about it again and make sure people are aware. We have resources and books that are readily available to our staff that have numbers of locations that patients can go to, whether it's shelters, community outreach programs. It has that all available. And staff is very diligent at looking at that. In fact, I saw a couple staff members using it last night, for example. So it is used quite well. I know the staff also have really good relationships with our peer recovery coaches and take those opportunities to really chat with them and talk with them as well. Not just nursing, but I'll include in there our providers as well. So I think that it's a learning process and everything in the ED is always about learning. So taking that information that we can get from the peer recovery coaches and then using that, and then that's just kind of brought on amongst staff. So we appreciate that really great relationship with them.
As an OSOP coach, when I first started, the program was brand new. So what I did is I took the initiative and I called every treatment center up. I want to come meet y'all. It was like, fool, are you crazy? You can't just come in here, HIPAA laws. But a couple did let me in and talk to me. But providers, pathways, the community centers. So I just set up meetings and I went to meet people. Unity Health, I met Dr. Roby. He was nice enough to bring me in, show me around the facility. So, building those bonds, it starts the program. Plus, sometimes when you call people, I'm a quiet person, so, it's kind of cold. But when you meet them, it helps out. I've learned that in DC, if you got Medicaid, it's one simple process. Get them to an APRA center, get the referral. Once we get the patient out the door, they got them. And they will get them into treatment. The biggest barrier was Medicare. After 11 months of working, I got my first Medicare patient and it drove me crazy. I couldn't get them nowhere. So fortunately, I found one place. Maryland patients, it's a little different. It takes time. So if a patient comes into the ED and they're being discharged that same day, with Maryland, you have to send clinicals over. And then their doctors' teams will look at it and then they will accept the patient. So Maryland takes a little bit of time. So, like she said, Sam said, communicating with the peer recovery coaches, with people who have experience, they've been there, they've done that, they make the job easier. I've worked with one of the doctors at the hospital and one of the social workers, and we put together a one-page sheet. And I believe the idea was when they were discharged, if they went through the SBIRT process, that one-page sheet had the detox centers, treatment centers in Maryland, DC, Virginia. It's like a handout. So I just emailed it to everybody so they would have it. So just spreading information, trying to make people's jobs easier, because, if you take time to do the hard work and the leg work, you can help somebody, make their job easier.
We're all on the same team. Got to make it easier for each other. So coming back to a point you mentioned earlier, Keith, and I think I would pose this for all three of you. In terms of, clearly COVID has been a stressful time for so many people, and that's something that I think in terms of the patient. Sam, you showed some of the data in the ED, while the number of encounters are down, the rate of positive screen stays the same. So there's fewer people, but a higher percentage are screening positive. But also from your own perspective, if you're willing to share some of, I mean, you're in an extremely busy emergency department and everything that these past 6 months have been, what are some strategies that you've employed in your different roles to kind of take care of yourselves and make sure that even as you're continuing to provide these services for our patients, we're also taking care of ourselves as well?
Yeah, well, obviously PPE, but we've had to learn, like I said earlier, just different types of models and how we do things. Previously, you could go in the room and medicate a person, and then, or start your assessment, medicate, and then go back and ask them about the SBIRT. If you come into your room, go in and out of the room several times. Now we're finding that we can't really do that, and PPE is important. We need to protect ourselves. So we're doing a lot more of this kind of cluster caring. We've always kind of abided by cluster care, but right now it's of the utmost importance because you want to limit your exposures to some of these patients. So we've tried to remind people whenever you're going in to do your assessment, just make sure that you ask these questions with it. And I think that has really become part of the nurses' mantra. It's become a big part of their assessment. They ask these questions whenever they go in, so they don't have to go in again and ask. Like I said, if they do forget to ask, we installed those phones in the rooms. It's so easy. They can call from the outside. The numbers are on the outside of the door that they can just call the number. The patient has their phone right there. They can answer it. They can ask them those questions real quickly. I've gotten feedback, but that's not as, I guess, they can still ask the patients these questions, but they're not really getting into having a good conversation with those patients. So they do appreciate how it was before if they wanted to go in and have a little bit more of a talk with that, but they're definitely finding they don't have that opportunity to sit and chat with them as much as they could previously. That's definitely not a positive, but we're working with it. And just like you said, Elizabeth, we have to make sure that we are keeping ourselves safe, but we're also keeping our patients safe as well. So just limiting those interactions and making sure that we have that PPE on really helps to at least make the situation a little bit better.
Dr. Griffin, is there anything that you would want to add to that?
I think that they've done a great job of explaining. I also do want to say that our physicians here at MedStar Washington Hospital Center and throughout the entire MedStar system in psychiatry are all buprenorphine trained. They have the waiver. They're able to administer. So we do administer it on the inpatient units. We'll be looking at, we also like the collaborative aspect of this program because we're able to interact and work with so many of the teams out in the community, the different agencies, the different facilities for detox, for treatment. In a way, we are a link to different levels of care out in the community, and it's a very holistic wraparound type of approach for these patients. So I think it's great. I think this grant and program is very helpful, and it's been way overdue for a long time. So, and the team does great. The ED team does great. The peer recovery coaches are great. So thank you, and you guys have been great. You guys helped us, trained us, and helped start the program. So big kudos to all of you and to Mosaic, have been very helpful here in the district.
Excellent. I think on that note, it's a positive note to end on. Thank all three of you, like you said, as well, the leadership team at Washington Hospital Center and Mosaic Group, everyone who's a part of making these happen and kind of rolling with the punches the last 6 months. I'm really grateful for all of you. Dr. Griffin, you kind of led us in perfectly to our last session of the symposium. We have a prescribing MAT, physician perspective, and booster training from Dr. Mike Fingerhood, physician at Johns Hopkins. So in terms of prescribing that buprenorphine and getting the dose, he will lead us off. So with that, thank you. We will take a quick 5-minute pause and be back at 2 o'clock.
Alrighty. Thanks.
Thank you.
Bye-bye.
Hi,
Dr.
everyone.
Altocky.
Hi, good afternoon.
Hi, Dr. Fingerhood. How are you?
He's muted.
No problem.
He's adjusting his background. We have some kids' art in the background. Hope you don't mind.
Beautiful. Brightens things up. As we're getting ready to start, I'll just do a couple quick reminders. This presentation is eligible for continuing education credits for physicians and nurses. In order to receive credit for your participation today, we do need to make sure we capture you. If you've logged on from a computer with the link you received upon registration, you should be good. If you're in a room with multiple people, please email jgonzalez@dcha.org with a list of names and email addresses of everyone in the room with you who intends to receive the credits. Also, please send an email to jgonzalez@dcha.org if you're dialing in from your phone only and you're not on a computer, or if you didn't use your unique registration link. So if someone forwarded you the link to the webinar today, please send an email to Julie. That email address is in the chat. We will also be sending a post survey at 3 o'clock today at the end of our sessions that must be completed in order to receive continuing education credits. If you have any questions about either Zoom or for our presenter, feel free to use the Q&A function at the bottom of your screen. We will make sure they're answered as we go, and questions for Dr. Fingerhood will be answered at the end. And the chat has been disabled for this session. A final note, the symposium is being recorded. On-demand sessions will be available following all the presentations live through our website. So the credits are only offered for live participation. So with that, we're going to take about a 2-minute break. And at 2 o'clock, Dr. Altocky, we will get started.
Fantastic.
Alrighty, so it is 2 o'clock. We're going to have Dr. Nadia Altocky. She's the Director of Clinical Operations in the Department of Emergency Medicine at Sibley Memorial Hospital, so part of Hopkins in DC. Introduce our speaker today. Dr. Altocky.
Thank you. Good afternoon, everyone. I'm Nadia Altocky, and I'm delighted to introduce the final session of this symposium. This is a special session specifically designed for physicians around prescribing medication-assisted treatment, including common barriers and best practices. Our presenter this afternoon is Dr. Michael Fingerhood. Dr. Michael Fingerhood is an Associate Professor of Medicine and Public Health at the Johns Hopkins University. His clinical areas of expertise include addiction medicine and internal medicine. He earned his medical degree from the Albert Einstein College of Medicine of Yeshiva University and completed his residency at Johns Hopkins. Dr. Fingerhood's research interests include substance abuse disorders, contingency management, hepatitis C, and HIV. He is a member of several professional organizations, including the American Society of Addiction Medicine, the American Academy of HIV Medicine, the Society of General Internal Medicine, and the American College of Physicians. Without further ado, I present you Dr. Fingerhood.
Thanks. So I'm going to go ahead and share screen. Is that correct?
Perfect. Yes. Go ahead. Alrighty, we can see it.
So we're good?
We are good. Thank you.
Okay.
It's not in presentation mode.
Oh,
It's
all right. Let me, okay. Now,
it's still in the PowerPoint. I saw that you pressed
yeah, I
the
did.
button.
Let me go back. Sorry.
No, no problem.
Maybe I shared the,
I can also pull them up if that would be helpful.
want to go ahead? You can go ahead. Because I have two screens. I think I just pulled up the wrong one.
No problem. Can everyone see that?
Thank you.
Great.
So thank you for having me, and I guess this has to provide some meaning since it's the last talk, and hopefully people have learned a lot going through this. I apologize if there's any moments of repetition. I tried to look through to make the presentation distinct. Next slide. So I have no disclosures except a strong compassion for integrating addiction treatment into medical care in all types of settings, including the emergency department setting. Next slide. These are the objectives: to increase knowledge of opioid use disorder and to convince that addressing opioid use disorder in the emergency room is beneficial. And I'll say, not only when I say beneficial, I think that obviously we're patient-centered, but I think as I reflect on the work I've done to take care of patients with opioid use disorder, the beneficial aspect has been for me as a provider. And hearing patients come back to know how much we can impact their lives by helping them address opioid use disorder in a medical way. Next slide. So I'm going to present two patient vignettes, and you'll get the idea of why they're distinct. But to realize that we see patients in different stages, and all patients are different, and that we should always be patient-centered. This is the ideal patient, and I hope some of you have seen this patient. And I've taken care of many patients like this. He's a 34-year-old man found unresponsive by EMS who was awakened with naloxone, brought to the emergency department. He's now agitated, complaining of opioid withdrawal. He denies methadone treatment, which I think you should know, because it's concerning whether or not you can have two-phase withdrawal. And after discussion, he's convinced to stay and receive a dose of buprenorphine. So someone who's recently received naloxone is ideal because they're already in withdrawal, and like this patient, within minutes feels better. He meets with a peer recovery coach, which I hope most of you have in the emergency room setting, and is interested in continued buprenorphine treatment. He leaves, and this is the ideal, a naloxone kit, a bridge script for buprenorphine, and an outpatient appointment. I just want to mention that the naloxone kit is a goal that we're working on within Hopkins, and that will cover actually all the Hopkins hospitals, including Sibley and Suburban, as well as Hopkins Hospital and Hopkins Bayview. And there's some workaround because historically patients received a prescription for naloxone. Obviously, there's a big difference receiving naloxone itself. In most emergency room settings, the medications are administered but not dispensed. So there is some workaround related to electronic health record. The next slide. Patient vignette 2 happens as well. So this is just a different path. I don't know if you've seen the movie Sliding Door. So this just means that a different door open. Same person, denies methadone treatment. After discussion of options, he states he just wants to leave. He meets with a peer recovery coach, is given a naloxone kit and contact information should he change his mind. And realize that you're going to see this patient as well, and that's okay. And that we shouldn't be upset when some patients are not willing to accept initiation of treatment at that point, but it's an entry point, and they may hold on to that phone number. They'll remember the conversation with the peer recovery coach, and they'll know how to reach the peer recovery coach should they change their mind. Next slide. So this is a little bit my story of how I arrived to be here today giving this webinar. So I grew up in Brooklyn, New York, and in 1974, in this apartment building in Brooklyn, this was just after the Vietnam War. This was an early wave of heroin resulting in opioid use disorder. And in the bottom of this building, a methadone treatment program opened. I was young at that point, so I didn't know that much about it, but I actually lived in this apartment building. In reflecting even years later, I realized that curiosity certainly led me to do more reading and trying to understand addiction in 1974 as I was living in this apartment building. Next slide. So this is 10 years later, and at this point I was a medical student in the Bronx, and 1984 was the initial aspect of HIV. So in fact, in spring of 1984, during my pediatric rotation, I took care of my first patient with HIV. This is Jacoby Hospital in the Bronx. And opioid use disorder was rampant. Complications of injection drug use were present in almost every patient we admitted. I did 12 weeks of medicine rotation. I did a month in the emergency department. I rode ambulances around the Bronx. And heroin was king for sure. Next slide. And this is with the admission board. So I did a sub-internship then in the spring of 1986. And as we admitted patients, this is what the board said. And this was the very depersonalized acronym used as patients were being admitted. Unfortunately, people were numb to the experience. This acronym was used in the emergency department as well, and it stands for shooter with a fever. And the majority of admissions, I'd say at least 50 to 60%, sometimes frequently on some nights 100% of admissions, had this acronym placed next to their name. And it seemed pretty obvious that as we admitted patients that we were missing something. We seemed to be doing blood cultures, and if there was a murmur, we did echocardiogram, and then we sent the patients out. And I remember saying to my attending, it seems that we're missing something here, that usually that we should be treating the underlying illness or disease and not a symptom that happens as a result. The answer I received was that this was not a medical problem and there's nothing we could do about it. So everybody who's listening to this webinar today is doing so because the realization that my attending back then was clearly wrong, and there is something that as medical providers that we can do about it. Next slide. So this is what we have to do, and I'm going to present some more slides on this topic as well, but we all have to be aware of our own views and do a self-inventory of how we think about individuals with addiction and opioid use disorder, and realize that labels are detrimental. And people are what you label them. So even the term addict is something that we should avoid. I get frustrated with the New York Times, who continues to use that term. If anybody watched the debate last night, there was just a horrendous interaction about Joe Biden's son who had addiction, with the detrimental term being used. In journalism, I've presented at science writers meetings, and most entities now have come away from using stigmatizing language, but it's still prevalent, including the New York Times. So I encourage everybody to be careful about the language we use, and I'll talk more about that in a few minutes. Next slide. So this is clearly a shower, right? So the reason you take a shower is to get clean. And this is what individuals do when they take a shower, they get clean. When someone enters treatment, they enter treatment. When someone's in recovery, they're in recovery or in remission, but they're not getting clean. The only way to get clean is to take a shower. And I over and over again, I try to correct patients also. Now, in terms of language, I just want to say that I've had some patients say, well, isn't it different if I'm at an NA meeting or an AA meeting, and obviously people introduce themselves and say, hi, I'm so-and-so, I'm an addict or I'm an alcoholic. And perhaps that's a little bit different, but I do let patients know that outside of that setting, it clearly is not right, and it perpetuates stigma And perhaps even in those settings, it's wrong to do because it's self-inflicted stigma as well. Next slide. So this is the famous painting by Edvard Munch, a Norwegian painter, and most of you know it as The Scream. About a decade ago, I got invited to actually give some talks in Norway related to addiction. I went to the Edvard Munch Museum, and it wasn't until that point that I learned that the real name of that painting is Despair. It's not The Scream, it's Despair. And Edvard Munch battled alcohol use disorder his whole life, and he frequently went away to a sanitarium and came back. There are multiple paintings called The Scream, but it's believed that it's actually the way Edvard Munch feels with his frustration over just not being able to maintain sobriety. But I think it's the way patients feel. There's really not many synonyms to despair. It's a mixture of so much emotion. But I also want to point out that for many providers, it's all right to feel that as you try to take care of patients who come in with opioid use disorder, that you feel some despair. But the aim of this is to realize that despite a sense of despair, that what we're going to talk about is not futile. Next slide. So how old is this concept that we should be thinking of substance use disorder in a medical context? So in 2006, the Institute of Medicine released a report recommending improvement in coordination of mental health and substance-related services into general health care services. And this is a quote: "Studies of health delivery, process of care, and health outcomes in integrated clinical settings will be critical to inform the process." So, certainly the emergency department is one of those clinical settings that's crucial. Next slide. So I'm going to share a couple of papers that I did with medical students. This one strictly qualitative. And this was looking at what should providers expect from their patients with addiction. And there's a nuance here, so I'm going to say it again. So the first aspect is what providers should expect. And these seem obvious, but these were from qualitative interviews, and we then distilled the themes. A desire to receive care that will improve health, an engagement in care based on trust and rapport. Seemingly, these should be part of any interaction with a patient, between a care provider and a patient. But again, this is what the patients feel the provider should expect. Next slide. Then this is a flip of that. What do patients with addiction need from their providers? Knowledge about addiction, a duty to treat. And the word there, duty, is from the patients, and it was used by over 50% of the patients. It's a pretty strong word. And in fact, it seems like it should be implicit in what we do, but it's not. And historically, there are many providers who, like the attending I met in the Bronx, felt there was no duty to treat because this wasn't a health problem. So this implies that, in fact, health providers have a duty to treat people who have opioid use disorder, who have addiction, and it is within the realm of healthcare. And then the last one is really important, is to engage patients in care. We all have our own styles, but the style has to include being adept and skillful in how we engage patients in care, showing that we care, showing empathy, and really giving patients hope. Next slide. So what about emergency physicians? So this was also with Cece Mendel was a medical student. Giorgio Galetto is a Hopkins emergency department physician. He's associate professor of medicine as well. And when we decided to look at attitudes towards patients with substance use disorder, we thought it best to team up with an emergency provider who would send out the survey and to gain approval from individuals who worked in the emergency department. So this was actually specifically emergency department physicians, including some trainees. And to quickly summarize, physicians had lower regard for patients with substance use than any other medical condition with behavioral components. Next slide. So these are just some examples, right? So 8% of participants agreed that working with patients with substance use who have pain is satisfying. But the real contrast here is you could say, well, you know, hopefully that there's some patients that you do feel satisfying. And obviously, giving this talk because I find it totally satisfying to take care of patients with substance abuse because of doing it so long and seeing how patients change. But 29% agreed that working with patients with poorly controlled diabetes who have poor diet is satisfying, and 50% agreed that working with patients with COPD who smoke is satisfying. Now, I just want to put this in the context, and I'll remind you of this later on, in that if I give my best effort at helping someone quit smoking who has COPD, and I try whatever I can, varenicline, nicotine replacements. These are patients who perhaps even have severe lung disease. I'm lucky in 6 months if 10% of those individuals have stopped smoking. I'm going to show you slides in a few minutes to show that with my best effort, I can get 60 to 80% of patients with opioid use disorder in recovery at 6 months. Yet the answer here does not indicate the fact of how many fold easier it is to help someone with opioid use disorder than someone with lung disease who smokes. Next slide. And also in this study, 54% of physician respondents indicated that they agree that they prefer not to work with patients with substance use who have pain, and 54% agree that patients like this irritate me. Next slide. So when did all of this really take off? So this is a slide meant to show the wave of fentanyl. So it was 3 to 4 years ago, about 2016, that really saw fentanyl take off. For about 2 years, we saw carfentanil, which was enough to knock out this elephant. And then more recently, it's been fentanyl. And if you look at, I sit on the Baltimore City Health Department Opioid Overdose Fatality Review Committee. If you look at opioid overdoses in the first half of this year, they were all related to fentanyl. There's very little heroin that's out there. Even if someone thinks they're buying heroin, they're buying fentanyl. Next slide. So just one quick reminder, you may have done this already, but I think it's useful because we often use these terms interchangeably, and years ago I learned not to. So opiates are natural occurring. So that means morphine coated in thebaine. Opioids are manufactured. Under the manufactured, there are synthetics and semi-synthetics. Semi-synthetics are heroin from morphine. And then buprenorphine and oxycodone both come from thebaine. Synthetics are completely man-made, methadone, and then all the fentanyls with the fentanyl analogs. The reason it's important to know this is that if you're going to do a urine drug screen, realize these differences. So morphine, heroin, codeine will all come up similarly in a urine drug screen. Most drug screens, you have to ask for oxycodone separately, you have to ask for buprenorphine separately, you have to ask for methadone separately, and most importantly, you have to ask for fentanyl separately. There are still some drug use screens that do not automatically incorporate fentanyl testing, and you must order it separately. Next slide. So this is just some history to understand how we got where we are now with the consideration of using medications for opioid use disorder. In 1914, the Harrison Narcotic Act said that a physician could no longer, if someone came to their office and said, I'm in morphine withdrawal or tincture of opium withdrawal, and I need help, until 1914, a physician could prescribe morphine elixir with a schedule to try to help that person stop using morphine. As a result of that act, which was really a tax act, that could no longer happen. So you could no longer prescribe any opioid for treatment of opioid withdrawal. There was a physician in 1925 who challenged it, seemingly won, but that practice continued. It wasn't until 50 years later, than 1964, that methadone was introduced as an experimental treatment for opioid addiction. There was Rockefeller Institute in New York, And I showed you that by the early 70s, there were, especially in urban areas such as New York City, there were methadone treatment programs popping up actually throughout the city. I'll go through quickly some rules related to methadone in a few minutes. Then in 1968, the Bureau of Narcotic and Dangerous Drugs was formed, became the DEA, and through that entity, rules were made for methadone, which we'll go through in a minute, that clearly delineated how methadone had to be used for treating opioid use disorder, and also created scheduling of drugs. Next slide. Just to review opioid use disorder, I think you know these, we do this really quickly. It's now divided in DSM-5 into 4 groups: impaired control, social impairment, next slide, risky use, and then pharmacologic dependence. It's important to realize that the pharmacologic dependence can occur outside of opioid use disorder. So if someone has been prescribed opioids long enough, they can have pharmacologic dependence. And that's part of the reason we've come up with rules. For instance, after a surgical procedure, that a patient doesn't receive 30 days of prescription opioids, because if they indeed took that prescription opioid for 30 days, they likely would have pharmacologic dependence. Next slide. So how do we identify patients with opioid use disorder? Sometimes it's by ask. Obviously, if someone has come in with an opioid overdose, we know. There are various screening tools that we're not going to review. There's an assessment based on constellation of symptoms, local medical record, and CRISP in the PDMP. The CRISP in Maryland now actually flags someone who's had a non-fatal opioid overdose that was seen in an emergency department setting. It's also important to look at a PDMP to see if someone is receiving opioids from multiple providers. But it is important to realize, though, that the PDMP and CRISP will not indicate if someone is receiving methadone through outpatient treatment program. There's a call to change that, and through new SAMHSA rules, patients can now opt in to be included, but most patients have not. That has not happened. It's some work on the part of the treatment program. So it is a difficulty, especially I think if you're in an emergency department setting, of not knowing that someone is on methadone based on looking at anything that's at your disposal. Next slide. So this is what I'd like to say. I know that you presented SBIRT, and I know Mosaic's grant is called SBIRT, but in fact, I'm going to say that what you're doing actually, and hopefully in the emergency department setting, is you're screening. In many instances, you're not screening because you're going to know. If someone, for instance, comes with an overdose, that's a positive screen automatically, you're going to intervene and treat. So it would be nice if we changed the acronym to screen, intervene, and treat, knowing that after that treat, there may be an R afterwards. But the encouragement here is to do this. Next slide. So what can you do as a provider in any setting? I always work with patients. I emphasize health and life benefits. I try to use family and friends in a positive way. I give hope, try to give hope that life can improve, and that's very patient-centered. Acknowledge reasons for use, but, so it doesn't mean the patient ever has to say, I don't like getting high. Patients get high because they like the way it makes them feel, although as I'll show you in a few slides, that eventually they're trapped and they're using to not get sick. But at the same time, it is important to realize for most substance use disorders, patients use because they like the way it makes them feel. But we talk together to define the benefits of change, and the benefits should outweigh the reasons that they have been using. Next slide. This is the traditional approach, which was very 12-step oriented. For some patients, it worked, but for the majority of patients, especially as we've had re-emerging waves of opioid use disorder and opioid overdose deaths, this has been recognized as helping only a low % of patients. Next slide. Just quickly about naltrexone for opioid use disorder. It's a pure opioid blocker. It's available as oral drug and monthly injection. Acceptance is poor. there's really little evidence for long-term efficacy. There's a concern that it may even increase the risk of opioid overdose. Several large cohort studies showing that this, in fact, may be true. And I really can't think of an indication for use in the emergency department setting. Next slide. So this is 23 years ago, there was a conference on effective treatment of opiate addiction. You could actually click through all the bullet points, right? So the emphasis here was that it's a brain-related medical disorder that, although a drug-free state represents an optimal treatment goal, I would take some argument with that. Research has demonstrated that this goal cannot be achieved or sustained by the majority of opiate-dependent people, and that is definitely still true in 2020. There's a call to reduce regulation of agonist treatment and to improve training of healthcare professionals in treatment of opiate dependence, and that's why we're having this today, and I think we'll be having these kind of talks for a long time. Next slide. So this is what I was alluding to before. So early on, this was from slides out of Rockefeller Institute in New York, the people who were the first proponents of methadone, adult Nicewinder and Creek. So each point early on is when someone uses heroin, and you can see that they wake up, they're sick, they use multiple times a day to try to get to feel high and euphoric. And then eventually what happens further on is they wake up sick, and the only thing that happens when they use is they feel subtly normal. And the last point is when they actually overdose. So eventually what happens is that use becomes a way of not feeling sick. That the amount of time you spend euphoric or high is minimal compared to how much time you spend feeling sick. Next slide. So I know in the introduction this was called medication-assisted treatment. So I'm going to hopefully over time win what's been a surmountable battle to get MAT changed to the term, which is preferred, and SAMHSA now uses this term as well, medications for addiction treatment. It's the medication for opioid use disorder. It's the medication that's really the focus, and it's other things that assist, but the medication is the focus. Next slide. This was those same researchers who showed that if you gave someone a dose of methadone, what would happen is if they used heroin, you can see they've stabilized the methadone, they use some heroin, they may feel slightly on a scale of feeling good, slightly elevated, but because their receptors are taken up, they don't get high, and obviously by getting dosed each day, they don't get sick. And the hope is over time, if you extinguish the fact and you realize that when you use heroin you don't get high, that you stop using. Next slide. And this was just a slide to illustrate that there's regression. So if someone is on methadone maintenance, the likelihood that they're going to use injection drugs diminishes with time. I could say that if they come off, that'll increase. But this is important to realize that people still test, whether it be methadone or buprenorphine. If you look at have you used in the past 30 days, either heroin or fentanyl or whatever you're buying as a street opioid, the first few weeks there's intermittent testing, and eventually it does go away. But people shouldn't think they're a failure if they're still testing and using. But clearly, for most patients, there's tremendous decrease in risk of overdose. Next slide. So this was data 2000 when so many things changed. It was meant for the first time that a physician, at this point just a physician, who has a patient come to him or her with opioid withdrawal, that the physician could do something. Until this point, since in the mid-60s, the patient had to be referred to an opioid treatment program, and we'll talk about that in a minute. But it meant that with this training, that physicians could now prescribe a medication for opioid use disorder, opioid dependence, and that was buprenorphine. Next slide. So this is a changing approach. These just to compare. The main differences were for methadone treatment, there was 12 months of use. Buprenorphine, there's no time criteria. That providers set the dose. You can see the age difference. For methadone, you had to be 18, buprenorphine 16. that this was a prescription that was written, patients fill in the pharmacy, and that services must be available, meaning counseling services. Next slide. So buprenorphine is rather unique. Buprenorphine was first described by a mentor of mine, Don Jasinski, in a paper in 1976, so 44 years ago. He first suggested that this molecule, because of its properties, was a mixed agonist-antagonist. It had a long half-life. It had to be administered sublingually, and it was more had higher affinity for the mu receptor than other opiates, which obviously means that it'll knock other opiates off the receptor, and if someone has been on a full agonist, you'll actually precipitate withdrawal. Next slide. And the important things, early on there was a question of whether it also caused QT prolongation. It does not. There is no concern of hepatic toxicity. I've prescribed it in patients even with cirrhosis. We have an addiction medicine consult service in the hospital. One of our most common consults is, I was on the consult service 2 weeks ago, we had 3 of them, individuals with QT prolongation who needed to be switched from methadone to buprenorphine as a result. One of the patients actually presented in ventricular tachycardia related to Torsades. There's a ceiling preventing respiratory depression. The only reports of respiratory depression have been in very young children under the age of 2. And it into itself does not contribute to overdose because of the ceiling effect, in which it does not cause respiratory depression. And again, no significant interactions with other drugs. Next slide. So I'm going to say that we should stop using this term. This is meant to show induction. It really bothers me that because there's so many instances where I've heard providers say, well, I'll take someone who's been on buprenorphine, but I won't induct them. And I have to say in care settings, as an internal medicine primary care physician, it's obviously enormously more difficult to initiate insulin than it is buprenorphine. And we don't create a separate term. I mean, even the use of naltrexone, which is really difficult because it's a pure blocker, the term is used initiation, but for buprenorphine, it's induction. It's been, I think, an impediment to more people being willing to consider prescribing buprenorphine because of the term induction. Next slide. So what about starting buprenorphine? The emergency department is an ideal setting as patients present seeking help, in withdrawal, or having just received naloxone for an overdose. So unlike many other settings where you may say, well, I have to wait, they showed up to my office and they just used even though they weren't going to, I'm going to hope that they're going to know to not take their first dose until they're in significant withdrawal. You can start. So if patient is in withdrawal, and obviously besides their complaints, you can look at their pupils, right? Someone who's under the influence of opioids will have pinpoint pupils, so they should not have pinpoint pupils. You can give a test dose of 2 milligrams. And in the setting, especially of recent fentanyl use, I would say repeating 2 milligram doses every 1 to 2 hours is usually the way to go. If someone, most patients, as in the patient I presented at the beginning, if they're in withdrawal and they just received naloxone, they actually will feel better from a dose of buprenorphine 2 milligrams. Again, starting slow is really crucial. Next slide. So what's the evidence for starting buprenorphine in the emergency room? So these are really crucial papers. This one, realize, is a clinical trial. So there's some thought that, well, is there a clinical trial effect if patients agree to be in a clinical trial? But the 104 patients randomized to referral group, 111 to brief intervention, and 114 buprenorphine treatment, meaning they received their first dose of buprenorphine in the emergency department setting. So 78% of patients in the buprenorphine group versus 37% in the referral group and 45% in the brief intervention group were engaged in addiction treatment on the 30th day after randomization. So it's easy to see that that's significant. So receiving the first dose in the emergency department setting doubled the likelihood that they were still going to be in treatment at 30 days. Next slide. So this was a study, and is it really worth it? So this was just published, American Journal of Emergency Medicine, with actually the Mosaic group people that you probably have heard from. I'm sorry, the typo, it's Mitchell. And Robert Schwartz is the senior author. Robert's a Brooklyn guy like me. We grew up actually a few blocks away from each other in Brooklyn. And this was a huge study. So it was over 1 million emergency department patients screened over 4 years in Maryland. 17% screened positive for problematic alcohol or any drug use in the previous 12 months. So 1 in 6, over a little over 1 in 6, which is huge. That means it's over 160,000 people. Nearly 80,000 brief interventions were delivered, most often by peer recovery coaches. 15,900 referrals to outpatient treatment were made, and 38% of those were successfully linked to treatment. So that's a lot of people linked to treatment. The next slide is the really punchline. So 950 patients exhibited opioid withdrawal symptoms. So almost 1,000. 70% were administered buprenorphine, which I think is pretty great. I wouldn't have realized that number would have been so high. And that's made, certainly this paper, I think, has made me really think of how impactful the emergency department is. And this is an incredible number. So 94.6% accepted a referral to buprenorphine treatment after receiving that dose. So you might think, well, did we ever make withdrawal worse? There's probably some of those patients that temporarily got a little worse, but almost 95% accepted a referral to continue buprenorphine. And this is an incredible number. So of those, this is still a huge number. Nearly 2/3 attended their first outpatient buprenorphine treatment visit. Obviously crucial to this, and I know this can be difficult, is creating those linkages to outpatient treatment for buprenorphine. Many emergency department settings have temporary bridge clinics. That wasn't true in this study, but in other cities, a frequent model, including up in New Haven, where the first study was from, was in case there was a delay to have some ability to continue to bridge patients temporarily till their primary care appointment. Next slide. So support groups, you're not in recovery if you're on medication. Support groups were not an essential part of these studies. That it was encouraged, peer recovery people stayed in touch, but also that there's sometimes problems with people going to 12-step meetings. COVID certainly has limited the use of 12-step meetings, but at the same time realized that a lot of these meetings, unfortunately, still continue to stigma medication. Next slide. So these are some things that you'll hear. Wow, I feel normal. I wake up not sick, I have my life back. Now, I always feel sorry sometimes that if you're in an emergency department setting, that the patient doesn't come back and tell you these things. And that's part of the sensation, I think, of why the answers we got in the emergency department are true. I get to hear this from patients, but a patient doesn't come back to the emergency department and say, do you remember me? I was here with an overdose 2 years ago. I've been in recovery ever since. I wish that would happen, and I think that's the essential piece in changing the way patients are viewed. Next slide. I just wanted, last couple minutes, just show you some comparisons. There may be patients who say, I'd prefer to be on methadone. And I think it is important for the emergency department to know where they can refer patients for methadone treatment. I have the luxury of having a methadone program here in Baltimore that will accept walk-ins, and that I can actually refer, that the emergency department here can refer patients. Like if someone is discharged from the emergency department in the morning, they can actually have their intake for methadone in the afternoon. Again, that's unfortunately not always true. But I just wanted, this is, I'm in the same building where I take care of patients in integrated care, primary care with buprenorphine. And we also have a methadone treatment program in the same building. So I just wanted to show you some quick comparisons so you're aware. Next slide. So these are just the differences, and this was published in that paper I just showed you, 2014. The ages were similar. There were some gender differences. Patients who opt for buprenorphine often have commercial insurance. That may be because of their commercial insurance not covering methadone treatment. Until this year, Medicare did not cover methadone treatment. And you can see that of our patients who are on buprenorphine, at that point, 45% are employed. Now, over half of our patients, the majority of our patients on buprenorphine for opioid use disorder are employed. Next slide. And most of the other things were pretty similar. We had a little bit more HIV infection because we provide HIV care. The other difference was that, and this may be after the fact, that there's a little bit more benzodiazepine use disorder in patients who are on methadone. Next slide. So I'm going to just summarize the slide quickly to say that in terms of retention and treatment at 12 months, not 6 months, 12 months, and the percent of urines that are negative for opioids at 12 months, the message here is buprenorphine and methadone are similar. There was no statistical difference. So I think it is correct to let patients be patient-centered and have patients sort out their options. If you're able to offer both and explain both, which we do on our consult service, we could say that the outcomes are similar and understand why patients might choose one versus the other. Next slide. So this is what we have to do with our patients. And unfortunately, in the emergency department setting, you'll see patients in the midst of dramatic shame. Next slide. So I just saw a patient this morning where we just discussed, I have a cartoon that shows this. The best thing you can do for yourself is stop using drugs. The patient, I don't deserve the best, what else can I do? This is a process, and certainly in the emergency department itself, it's tough to impact this process of how to improve this, but realize in the emergency room setting, this is where patients will be. Next slide. So coping is tough, and this is just to put in the background as we see patients to realize how complicated it is. We saw a patient on consult service, a young woman in her 20s who came in with pseudo seizures, who had a terrible history of PTSD, intimate partner violence, sexual assault from when she was a teenager, and obviously now with addiction. And all of these things have such complicated intertwining. And coping skills are something that are so essential that won't happen overnight. But just put that in the background as you see patients to realize that they have to develop. Next slide. So again, recovery is about progression. There are steps. There are slips. When patients use once, I say you didn't relapse, you slipped. And these are all things that have to happen. One of the things one of the reasons I have some negative views towards some 12-step meetings is I think that in 12-step meetings, people are told that they're powerless, when in fact, I try to empower patients that they can achieve success. So all the things important. I do ask patients to accept responsibility, but to stop blaming, meaning themselves or other people. And obviously, the most important thing we can do is create hope. And that is true in any medical setting, and especially in the emergency department setting. Next slide. So how much can I impact? This is almost the end. So I've shown you multiple studies have shown that the greatest predictor of fatal opioid overdose is a previous non-fatal overdose. So the risk is probably about 10-fold. Other risk factors were recently released from incarceration. But again, non-fatal overdose is one of the prime predictors of a fatal overdose. As I sit on the Baltimore City Overdose Fatality Review Committee, we always look back for every fatality, and it's not unusual to see 3, 5, 7 previous non-fatal overdoses. Initiated treatment in the emergency department is crucial, and that includes consideration of the use of buprenorphine or methadone, which we know are much more effective and save lives, and that we should also be given naloxone kits. Next slide. So this was the Hopkins Dome a few weeks ago for Opioid Overdose Week. It was lit up in purple, which was the color of that week. We've had Recovery Month in September as well. And I hope you received the message of how important this is as I take care of patients. I get emails every week from Hopkins faculty to help family members, children. I mean, it afflicts all aspects of our life, all socioeconomic strata. And I think we should all be eager to try to have an impact. Thank you.
Excellent. Thank you so much. A great way to finish this out. We're going to go into Q&A. I think we had one that you covered about the dosage, so thanks for touching on that. Can you talk a little bit more? I know you had mentioned a couple to me, resources that are available in real time for clinicians that are interested in prescribing maybe a consult for first or second dose.
Oh, yeah.
Also just the, so much of this is a social norm. We get, the critical mass, becomes the norm of how to treat these patients in the ED. So just kind of like how to improve groupthink around this and promote that as the norm.
Sure. So I'll put on so the first aspect is, and I don't know if you can send out the link. So we have the Maryland Addiction Consult Service, which is available to providers in the DC area as well. I verified that we'll accept offering help to people. There's a website with how to access it. And this is really to help with clinical questions. I've started on someone on buprenorphine, and I need some help. We can also help with outpatient linkages if there's a question of where can I send this patient as well. So the other thing, I'm in Baltimore, but I do have to say, and this is true for DC as people in DC as well, is that if you look at changes in opioid overdose, some of the greatest increases have been in suburban areas, I want to point out. So Montgomery and Prince George's County have both had two of the highest increases in opioid overdose fatalities in the Delmarva area. And suburban counties also, so Howard County had a tremendous increase as well. No matter where you are in terms of being an emergency department provider within DC or the suburbs around, you should be realizing that you have to make an impact.
Thank you. And just a reminder for our attendees, if you have any questions for Dr. Fingerhood, please use the Q&A feature at the bottom of your screen. We do have another question. Thank you for this insightful presentation. Is there a formalized process you use for consent to treatment? So that's a good question. So in the emergency department setting, I would say no. You would ask information if you were going to directly call to do something in terms of linking the patient to a program. If you're just getting information to linking that program, I do not. Now, in terms of my primary care setting, I do have a treatment agreement, and it's not a contract. I hate that term. So it's agreement of expectations that shows that with patients that we're going to team up in working towards recovery. And there's some detail on how to reach people after hours and things like that. But that's really so it's the consent to treatment would be the normal consent to treatment that patients receive when they enter an emergency department. Great, thank you. In terms of other members of the ED care team, maybe they're not someone who has the ability to prescribe, but what's the role of maybe other clinicians, social work, any of course we've talked about peer recovery specialists, others who might be able to promote this, even if the person who can prescribe maybe that's not the first thing they go to.
Yes, so I think that everybody should be knowledgeable. So on our consult service, we have physicians, we have a fellow, we also have peer recovery coaches, we have a health behavioral specialist who's a social worker. So we all work together in tandem. So it's important for all of those aspects to happen. So in the inpatient setting, we even have a nurse talks to a patient and believes a patient would benefit from addiction consult. We've empowered nurses to request consults. So every member of the care team, from peer recovery coach to nurse to social work, physician assistant, nurse practitioner, every member of the care team should feel empowered. And as of 2 years ago, nurse practitioners and physician assistants can also prescribe buprenorphine. There's a quick, I think it went away. In terms of dosing, I'll just answer really quickly. Someone asked, is there a ceiling dose for buprenorphine? In the setting of fentanyl, we've recently seen that it's not unusual for higher doses to be needed for maintenance. It's really the dose that seems to be most effective in taking away craving. In the emergency department setting, you're getting patients started, but in the outpatient setting with fentanyl, it's not unusual to see patients need 24 milligrams. It used to be the majority, 90% of my patients were on 16. I have many more patients now on a higher dose, I think just because of being treated for fentanyl dependence rather than other opioids.
Great, thank you. Well, it looks like that is the end of our questions. Thank you so much for being here today, for sharing your experience and your knowledge. Thank you to the attendees as well for your engagement. We will have a follow-up survey that we'll send immediately following this, and again in a few months, just to see kind of the impact and how behavior has changed, if at all. And with that, I'm going to hand it back over to Eden Cunningham, who opened our symposium on Monday, to close us out.
Hello. So yes, thanks Elizabeth. So just to close, I want to thank everyone for joining this event over the past 3 days. I also want to take a moment to thank our partners at the Department of Behavioral Health and our partners at the Mosaic Group who work to develop and implement our ED-based opioid response programs. We also want to thank our district hospital representatives, DC Health, the Department of Forensic Sciences, the Recovery Centers of America, and all who provided speaker introductions and wonderfully informative presentations for the event. And finally, I want to thank our team here at DCHA, Julie Gonzalez, Elizabeth Abrams, Gail Hurt, Jen Hurt, for supporting the organization of this event. And I want to thank our president and CEO, Jackie Bowens, for her leadership and for kicking us off on day 1 of the symposium. We hope you enjoyed each session and gained knowledge and skills needed to continue the great work you are doing to address the opioid crisis in the district. We will be sending all attendees a survey to share your experiences with the symposium, particularly because this is the first year we're doing an event like this virtually, so your feedback will be much appreciated. And again, thank you all for your attendance and your support, and enjoy the rest of your week.